Hi, and welcome to this topic in the module Respiratory Medicine, Pulmonary Vasculitis. By the end of this module, you should be able to address the diagnosis and management of patient with pulmonary vasculitis, for example, in the condition granulomatosis with polyangiitis, microscopic polyangiitis, and Churg-Strauss syndrome. Let's get started. Pulmonary vasculitis is a group of disorders characterized by the histopathologic finding of inflammation and destruction of the blood vessel wall. Vasculitis can be categorized based on the size of vessels that are affected, such as capillaries, venules, and arterioles, which are small and medium-sized arteries or large arteries like aorta. Vasculitis can also be recognized based on a biochemical test called the ANCHOR test, which is anti-neutrophilic cytoplasmic antibody test. The ANCHOR-mediated pulmonary vasculitis include granulomatosis with polyangiitis and microscopic polyangiitis, and immune complex-mediated pulmonary vasculitis include anti-GBM disease, IgA vasculitis, and cryoglobulinic vasculitis. Here, we will be discussing three conditions under the category of pulmonary vasculitis: granulomatosis with polyangiitis, or also known as Wegener's granulomatosis, microscopic polyangiitis, and Churg-Strauss syndrome. Granulomatosis with polyangiitis is now the preferred term for Wegener's granulomatosis. It is an autoimmune condition associated with a necrotizing granulomatous vasculitis, affecting both the upper and lower respiratory tracts as well as the kidneys. The classical triad consists of necrotizing granulomatous inflammation of the respiratory tract, glomerulonephritis, and small vessel vasculitis. Features include upper respiratory tract symptoms such as epistaxis, sinusitis, and nasal crusting, saddle-shaped nose deformity. Lower respiratory tract symptoms include dyspnea and hemoptysis. Rapidly progressive glomerulonephritis is usually present with rapidly progressing renal failure within 3 months, proteinuria, and microscopic hematuria. Other features also include vasculitic rash, proptosis, and cranial nerve lesion. Investigations that can be done to diagnose this disorder include a C-ANCHOR, which is positive in more than 90% of the time, specifically the PR3 ANCHOR. P-ANCHOR is also positive in about 25% of the time, and which is MPO ANCHOR. A chest X-ray may show a wide variety of presentations, include cavitating lung lesions. And lastly, a renal biopsy is done to confirm the diagnosis with an presence of epithelial crescents in Bowman's capsule. The management of granulomatosis with polyangiitis includes steroid therapy. So prednisolone is given in doses of around 1 mg per kilogram per day initially, after which the dose is reduced rapidly, typically at weekly intervals. In cases of renal failure with indications for dialysis, the initial management may include methylprednisolone, and this should be given immediately, followed by hemodialysis and then cyclophosphamide. The combination of prednisolone and cyclophosphamide is now established as the standard therapy and the treatment of choice for induction of remission in granulomatosis with polyangiitis, as 90% response is seen. Both rituximab and methotrexate have also been used for induction therapy in ANCHOR-associated vasculitis, although they would not be first-line treatment. Azathioprine is used as maintenance treatment for following cyclophosphamide, and lastly, plasma exchange. Microscopic polyangiitis is an ANCA-associated vasculitis. Patients with microscopic polyangiitis can develop pulmonary renal syndrome. They often present with pulmonary hemorrhage, albeit pulmonary involvement is less frequent than in granulomatosis polyangiitis and Churg-Strauss syndrome. It is similar to granulomatosis polyangiitis except in three aspects. It only affects small blood vessels in the lungs or kidneys. There's no nasopharyngeal damage like seen in Wegener's granulomatosis. It is associated with P-ANCA antibodies, anti-MPO more than anti-PR3. Antibody is strongly positive. There's no granuloma on biopsy. Other pulmonary complications of MPA may include radiographic infiltrates, pulmonary artery aneurysms, and fibrotic changes as well as airway disease. Churg-Strauss syndrome is typically characterized by the triad asthma, eosinophilia, and vasculitis. Churg-Strauss syndrome is described as having three progressive phases, which are the prodromal or allergic or atopic phase of asthma and rhinosinusitis, an eosinophilic phase in which eosinophil-rich inflammatory fluid infiltrates develop, and a vasculitic phase that presents with palpable purpura or mononeuritis multiplex. Upper airway involvement occurs in 70 to 90% of patients and is generally characterized by chronic rhinosinusitis with or without nasal polyposis, often lacking the destructive features found in patients with GPA. Asthma in Churg-Strauss syndrome commonly precedes the onset of the vasculitis phase and is often severe, frequently requiring oral corticosteroids. Extrapulmonary manifestations of Churg-Strauss syndrome may include constitutional symptoms, mononeuritis multiplex, cutaneous lesions, glomerular nephritis, and cardiac involvement. The cardiac involvement is of particular importance as roughly half of the attributable mortality in Churg-Strauss syndrome is due to cardiac complications that include cardiomyopathy, myocarditis, coronary arteritis, conduction delays, and sudden death. It is diagnosed clinically, although a biopsy should be sought for pathological confirmation. Skin biopsy reveals small vessel arteriopathy with granuloma formation and is the diagnostic investigation of choice. Blood vessels with extravascular eosinophils are seen on biopsy. Chest imaging demonstrates abnormalities in 70 to 90% of patients with Churg-Strauss syndrome, most commonly patchy, bilateral, heterogeneous, migratory infiltrates combined with features of airway disease. As for treatment, high-dose methylprednisolone with or without cyclophosphamide is the treatment of choice. GPA, MPA, and Churg-Strauss syndrome are classified as small vessel and ANCA-associated vasculitis. All three conditions may result in pulmonary involvement leading to fibrosis, alveolar hemorrhage, or airway disease. The classical triad for GPA is upper respiratory tract and renal involvement. Responds well with a combination of steroids and cyclophosphamide with plasma exchange. Churg-Strauss syndrome has predominantly lower respiratory tract involvement associated with mononeuritis multiplex, cutaneous lesions, and glomerular nephritis. It responds well to steroids. GPA is associated with C-ANCA, whereas MPA is associated with P-ANCA. We have come to the end of this module. Thank you.